Hello, my name is Ashley Ring, and today we're going to be going over some of the questions that were asked during the Slowing Down Kidney Disease webinar that Dr. Chen didn't get to answer. So Dr. Chen is joining us here to answer some of these questions. So getting started, what is the difference between CKD and PKD, and are there differences in the treatments of each condition?
Okay, so CKD stands for chronic kidney disease, and it encompasses anything in which there is decreased kidney function, and that can be from many, many different causes. And we spoke about diabetes and hypertension being some of the major factors in causing chronic kidney disease. PKD stands for polycystic kidney disease. And the main type of polycystic kidney disease is autosomal dominant polycystic kidney disease. Now what happens there is it usually is it is a genetically inherited disease in which numerous cysts start to replace the tissue of the kidneys. There's a gene defect that leads to cyst formation. And so polycystic kidney disease can lead to chronic kidney disease. When people have polycystic kidney disease, it is autosomal dominantly inherited, so that means a 1 in 2 chance you'll get it, and that is the major type, although there are other genes that can lead to cystic kidney disease. As far as the treatment, it depends on the cause for chronic kidney disease, but for polycystic kidney disease at the current time, our treatment options are limited, increasing water intake, limiting sodium intake, as proven by some studies, has improved, has slowed the progression of polycystic kidney disease. And there is a medicine called tolvaptan, which has been tried in Europe and is now FDA approved in the US, although the efficacy of that medication in slowing polycystic kidney disease and its progression are somewhat minimal or limited.
Thank you. So moving along, is it smart to replace some animal protein with other protein sources when you have chronic kidney disease?
Okay, so the major, a lot of trend right now is avoiding animal protein and substituting with plant-based protein such as tofu. Now, animal protein, especially red meats, have been linked with inflammation. And when you have certain disease conditions, chronic diseases such as diabetes and hypertension, inflammation can contribute to worsening of your chronic disease. So there is some research that suggests that animal protein is more inflammatory than plant-based sources. And so I think that, you know, in the talk we spoke about just being balanced and eating a balanced diet and staying away from processed foods, a lot of you know, packaged foods. But in terms of totally cutting out animal protein, I don't think that's particularly necessary, although there are some camps that say you should avoid most animal protein because of its inflammatory tendencies. So I would say just be smart about what kind of protein sources you eat. I mean, obviously, if you limit all animal protein, you're going to cut out a lot of food choices. So I would say just kind of mix it up and eat more vegetables and whole natural foods as opposed to packaged processed foods, and stay away from too much red meat.
Okay, thank you. That definitely makes sense. So our next question is, can primary aldosteronism cause CKD?
So primary aldosteronism is a very rare condition. When it occurs when there's a tumor, it's a benign tumor in your adrenal gland, and the adrenal gland produces many different types of hormones, including adrenaline and cortisol and aldosterone and other sex hormones. Aldosteronism is a state in which there is too much aldosterone, and aldosterone increases blood pressure, it causes sodium retention, and it causes potassium loss by affecting the kidney receptor and transporters in the kidneys that regulate sodium potassium transportation. So directly, no, it does not cause CKD, but indirectly it does by causing uncontrolled hypertension, high blood pressure. If you do have this very rare condition, sometimes it's missed in terms of diagnosis, and it can, if it's not treated correctly and blood pressure remains high, it can lead to chronic kidney disease. But the mediator of the chronic kidney disease is actually the high blood pressure, more so than just the aldosterone, although the aldosterone mediates the high blood pressure. So that the answer to that question is not directly, but it can lead to small vessel vascular disease caused by uncontrolled high blood pressure.
Right, thank you. Another question about causes of CKD. Does long-term use of Primolut-N cause CKD?
Okay, so that I looked up is it's a birth control product. It's a synthetic progesterone, and to my knowledge, birth control does not directly lead to chronic kidney disease.
Okay, thank you. So do you have any suggestions for how to stay hydrated even when you aren't thirsty or don't like to drink water?
Okay, so water is not your only choice of fluid. Any fluid can be flavored. You know, I tell my patients not to drink too many juices because that's all sugar. But other flavored drinks that are low in calories can be considered. The problem is, I think a lot of people, particularly as they get older, the thirst drive is diminished, and so they don't feel thirsty. So it actually is really a struggle to drink enough water, even though your brain should tell you drink more water if you're not hydrated. Some of the, if you take salt, that makes you more thirsty because it increases your thirst drive by signaling the brain that you need more water when you eat salty things or even drink more or eat things. Basically, that increase what we call osmolality in your blood. Anyway, that's a complicated way of saying that if you eat and drink things, your natural reflex is to drink, if you eat more salt and other things, your natural reflex is to drink more water. So I think that for people who don't like just plain water, adding lemon or some type of flavoring in that, I know some of these flavorings in terms of artificial sweeteners, there's some controversy in terms of its causing cancers and things like that. But, a little bit of flavor into the water often makes it more palatable. So I'd say, and particularly if you tend to get dehydrated, a little bit of sodium, I'm not saying to overdo it with salt, but that will drive your thirst up. And soups and any liquid is considered something that will hydrate you. You don't have to drink just plain water.
All right, thank you. So this is a personal question from someone who was on the webinar. They received a lab result that shows they're in CKD stage 3B, and they don't have high blood pressure or diabetes. They're wondering if they should see a nephrologist or a dietitian at that point.
Okay, so I tell patients to be careful about trying to interpret laboratory results that they get. Many patients get copies of these on the web, and they don't know how to interpret them. If your creatinine is elevated and it says that you do have diminished GFR, as we spoke about in the talk, if that's just one value, that could be because at that particular point in time your kidneys are not functioning at the level they should be. But stage 3B would indicate that you have GFR below 45, 30 to 45, which would probably be significant. Particularly if that measure has been verified at least one or two other times. So that means that something has affected your kidney function. Now, looking at the urine and your medications and other things are also going to be important in interpreting that lab test. I would talk to your primary care physician or the physician who ordered that laboratory test and ask them if they feel that that is of concern. Most of the time, if it is a verified result, it is of concern, and I would um, speak with them about whether seeing a nephrologist for getting a diagnosis would be advisable. If you do have stage 3B kidney disease, most oftentimes it's a good idea to see a kidney specialist to find the diagnosis, particularly if there might be some other treatment, if the cause is not specifically known, such as diabetes or something else.
Great, thank you. So another question about medications. Does using the medicine gabapentin increase my risk of getting kidney disease?
Gabapentin is widely used. It's a medicine that treats nerve pain or neuropathy. Oftentimes patients with diabetes are given gabapentin. It's a very effective medication in terms of particularly treating diabetic neuropathy, which is nerve damage from diabetes. It does not particularly cause any worsening in kidney function, although its dose can sometimes, if you're taking way too much and you have impaired kidney function, you might need to cut back on that because some of the side effects include getting sleepy and dizzy. So at most normal doses, like maybe 300 milligrams 3 times a day would be a fairly high dose or good dose if you need it. You need to be a little bit careful if you have advanced chronic kidney disease. Most times I recommend that you start off slow with gabapentin and go up slowly to see how much you need to get relief from nerve pain, and your physician, your primary care physician, or whoever prescribed it can help guide that. But I think more so I worry about overdosing with too much sleepiness, with too much gabapentin.
Okay, thank you. So our next question is, do you know the breakdown of CKD by stage? So example, what % of people have CKD stage 1, 2, 3, 4, and 5?
Okay, that was kind of summarized in an earlier slide by graph. I don't have all the statistics memorized. 14.5% or 8%, 14.8% of the U.S. population has chronic kidney disease. Most of those are in stage 3. Of the general population, probably 3 to 5% have stage 3 CKD, and stage 5 is very little, and dialysis is very little. Those are mentioned on a slide earlier in the talk. Then you can get that information from the National Kidney Foundation or online. If you refer to the previous slide there, you can see the graph, and it's remained relatively stable throughout the years.
Okay, thank you. So does severe stress, such as work-related stress, affect the kidneys?
Stress, stress is a difficult thing to define in a lot of, if you talk medically, stress can be physical stress from, disease states or illness. I think the stress you're talking about is probably mainly mediated by adrenaline and cortisol, which are the stress hormones that lead to the feeling of being overwhelmed and stressed due to the pressures of your job. These hormones, they do actually cause high blood pressure, and when you're under constant stress, that can certainly affect your blood pressure and subsequently your blood vessels. And we talked about high blood pressure leading to kidney disease by causing damage to your blood vessels all throughout the body, and in particular the kidney filtering blood vessels. In fact, many of the blood pressure medications we utilize, such as beta blockers, block the stress hormones such as adrenaline or epinephrine, norepinephrine, that raise blood pressure. So these beta blockers can be effective in lowering your blood pressure, and part of it, the mechanism, is by blocking those stress-related hormones. If you're under constant stress with increased cortisol, that can certainly lead to worsening health status overall. That can lead to higher incidence of diabetes and chronic disease. A lot of times, if you can't handle the stress, meaning you are particularly sensitive to the stress hormones and just the overwhelm nature of your work, I do suggest that you try to speak to someone in regards to better coping mechanisms, and perhaps if it's always a constant source of stress and affecting your overall health, I think that perhaps that job might not be particularly good for you. But as I said, stress in terms of defining it is a little bit difficult, but I think the biggest thing is high blood pressure and not controlling that high blood pressure. When you are exposed to constant stress, that's going to affect your kidneys.
That makes sense. Thank you. So our next question is, what are renal calculi and can this lead to CKD?
So renal calculi is just a fancy word for kidney stones. Now, kidney stones are very, very common. They are actual little rocks that form in your kidneys in the collecting system, such as where the urine collects, basically. When you form stones, usually you're predisposed to forming stones. That means there's something in your genetics that allows for the concentration and saturation of calcium and other substances within the kidney urinary collecting system. Kidney stones in themselves don't usually cause chronic kidney disease. However, if you form large stones or certain types of stones, those are related to things that can predispose to damage to the kidneys. Uric acid and uric acid stones are related to chronic kidney disease in some certain situations. They're not as common as calcium-containing kidney stones. If you have large kidney stones and they cause blockage to one of your kidneys or both of your kidneys for an extended period of time, this can lead to what we call obstructive uropathy, in which the urine is backed up because it can't drain and therefore causes damage to your kidneys or the kidney that it's blocking. So in rare cases, a large stone that doesn't pass can lead to chronic kidney disease, but oftentimes you're going to be in so much pain because these kidney stones are not painless that you're going to seek attention, and these kidney stones can be removed or will pass on their own. And a urologist, which is a surgical specialist in kidney disease, that's different from me, and nephrologist who manage the medical conditions, would be able to remove those stones. I often see patients with renal calculi or kidney stones and try to prevent any kidney stone formation because of the pain and suffering they can cause, and also if they do block part of the kidneys, they can lead to some damage. So I will work on the metabolic causes of kidney stone formation and decrease the chances that you will form a kidney stone.
Okay, thank you. So we had a question about the recommendation for sodium. So apparently the American Heart Association recommends less than 1,500 milligrams of sodium per day for people with high blood pressure. And they were wondering if you agree with this recommendation.
Yes, earlier in the talk, I spoke about 2.3 grams. That's what my dietitian recommends. You can't be perfect in terms of, monitoring all your sodium every single day, every day of the week, but I think you need to be smart and practical about it. I think about 2 grams plus or minus half a gram would be advisable if you have high blood pressure. Sodium and sodium retention causes more difficult control of high blood pressure. You need to speak to your primary care doctor or your nephrologist about, how much sodium to limit. You don't want to overdo it. You basically want to keep within a certain range, and I say about 2 grams would be reasonable. And that's what I recommended. But 1,500 milligrams is, if that's what the American Heart Association recommends, I think, plus minus, or 500 milligrams more than that is what I usually recommend. So I say around 2 grams.
Okay, thank you. So at what point do you recommend dialysis, and more specifically, at what creatinine and eGFR level, assuming that the patient is otherwise healthy?
So that's always a difficult, decision point. And I think that really depends on what your nephrologist and the patient discuss and decide upon. I am in the camp that I prefer to delay dialysis as long as possible, as long as the patient health is stable and they're not feeling the effects of decreased kidney function or having complications such as too much fluid in the body that we can't get rid of with medications. The general recommendation that I stand by is, we use medications to a certain point to help your body with the functions that the kidneys normally do. And when your kidneys can't do that as well, we use medications to assist that. Most people would say around 10, a GFR 10. Creatinine will depend on your age. But around 10 is where people start to feel that that their kidneys aren't doing the job, and we start having trouble with some of the things I mentioned with uremia, with blood pressure, with electrolytes. In patients who have more severe diseases with diabetes, heart failure, heart disease, sometimes we have to start earlier. Sometimes we can start till they're at 5% or a GFR 5. So I usually use GFR, and I say it as a percentage to make people more comfortable with that idea of GFR, because they understand what a percent is. So if you think of GFR as kind of a percent, when you're at 10% or GFR of 10, because when you're 20 years old, your GFR is 100. I'd say that's probably around the time when we start saying we should start dialysis. But even before that, I'd recommend planning for dialysis, because it takes several months sometimes to have a fistula and everything like that to prepare for dialysis. So that kind of question is a very important one to discuss with your nephrologist. And by the time you have chronic kidney disease to the point where you're going to need dialysis, you're going to be seeing a nephrologist, and that question is really going to be a focus as you're at stage 4 and 5 CKD.
Thank you. Your answer was very helpful. So after starting a low-salt diet, someone's blood pressure was averaging 114/80, and they were wondering, is that too low?
There's never like a set blood pressure that might be considered way too low, although a systolic under 100 might be considered quite low for someone if they have high blood pressure. But let's say you're pretty healthy, you don't have high blood pressure, and your blood pressure runs 100/50, and that's where you run all the time, and you have no symptoms. That's not a low blood pressure for you. We have to kind of gauge upon what your body is used to. As physicians, we look at norms, and your norm is going to be where you normally reside, so where your blood pressure normally is. Now, if your blood pressure was 170, 180 over 100, and now you're 114/80, I wouldn't expect that kind of drop in blood pressure with just a low salt diet. If you're really high and you do have more advanced high blood pressure or higher blood pressure, I don't think you'd get there with just a low salt diet. So I'm thinking your blood pressure probably wasn't too high. It was probably borderline, maybe 130/85 or something. And 114/80 is perfectly fine. In fact, that's a very good blood pressure for most people. So I would not say that's too low, but you have to gauge what your starting baseline blood pressure is, and if you feel poor with a lower blood pressure. Some of my patients who are 80 years old have a blood pressure of 140/90, and they feel terrible because their normal blood pressure runs much higher than that. So, and sometimes I won't push it, even though my goal might be 130/80, because I know this patient can't tolerate that low of a blood pressure, and it's all relative. So I would we look at patterns in medicine, so I wouldn't just take one number. I would take the average and see where you started to see if that might be too low for you.
Thank you. That's really good advice. So we actually have come to the conclusion of all of our questions. So thank you so much, Dr. Chen.
You're welcome.